Welcome to The Critical Edge, the no-nonsense podcast, breaking down the latest game-changing evidence in trauma and surgical critical care to give you the edge when things get critical.
Glad to be here for this one because the data we are looking at today is honestly going to turn a lot of established routines completely upside down.
Yeah, it really is. So what if I told you that nearly half of all inflamed appendixes, the ones that send people rushing to the ER, actually heal completely on their own without a scalpel?
Right.
And what if I also told you that 9 out of 10 emergency surgery patients are currently walking around with zero chemical protection against deadly blood clots, even though their doctors are following the hospital rulebook perfectly?
It's wild. It completely shatters this illusion we have of the fail-safe medical algorithm. We rely so heavily on standard operating procedures because they give us a sense of control, but biology doesn't always read the hospital rulebook.
Exactly. And that is exactly the tension we are exploring today. For decades, medicine has relied on these established playbooks. It's this comforting if-then algorithm like, if X happens in the body, we automatically do Y.
Mm-hmm.
But what happens when that default playbook either goes way too far or falls dangerously, silently short? Today, we are bringing you directly into that blind spot. We're on a mission to do a deep dive into two recent, frankly, game-changing medical studies that are actively challenging the standard protocols in emergency general surgery.
Yeah, we're looking at two highly specific scenarios. First, whether we actually need to cut out every single inflamed appendix that comes through the emergency room doors. And second, whether the standard dose of blood thinners given to almost every emergency surgical patient is actually leaving them entirely unprotected.
Right, so we have these two vastly different situations.
Yeah, it's a fascinating duality in modern surgical critical care. On one hand, we are examining a deeply entrenched protocol that might be exposing patients to unnecessary overtreatment. And on the other, we're looking at a widely accepted preventative measure that is resulting in massive, unrecognized undertreatment.
So both of them stem from that same reliance on standardized, one-size-fits-all algorithms. Okay, let's unpack this. Our stack of sources today centers on two major peer-reviewed papers.
Right.
The first is a 2024 block randomized study published in the journal Surgery. This one looks at active observation versus antibiotics for acute appendicitis. And our second source is a 2023 prospective cohort study from the Journal of the American College of Surgeons. That one analyzes enoxaparin dosing, which is a really common blood thinner for blood clot prevention, specifically in emergency general surgery patients.
So two totally different conditions, right? Operating in completely different bodily systems. Yet fundamentally, these researchers are asking the exact same question. Is the established population-level protocol actually working for the individual patient lying in the bed right in front of us?
Let's dive straight into the first paper, the appendicitis playbook.
Yeah.
I mean, when you hear the word appendicitis, there is really only one image that flashes into your mind.
The scalpel.
Right, the scalpel, the operating room. It is deeply ingrained in our cultural and medical baseline that an inflamed appendix means an immediate surgery, an appendectomy. And there's a historical reason for that, right? Since the late 1800s, an inflamed appendix has been viewed as a literal ticking time bomb in the abdomen.
Yeah, the rationale is built on the very real fear of perforation. So to visualize it, the appendix is a small, blind-ended tube connected to the cecum, which is basically the beginning of the large intestine. When it becomes obstructed, and this is usually by a hardened piece of stool called a fecalith, or sometimes by swollen lymphoid tissue, the mucus produced by the appendix has nowhere to go.
So the pressure just builds up.
Exactly. Pressure builds rapidly, and that intraluminal pressure eventually cuts off the venous blood flow, which leads to ischemia or, tissue death. Once the tissue dies, the bacteria from the gut translocate through the wall, the appendix ruptures, and suddenly you have highly toxic bacteria-laden feces spilling into the sterile abdominal cavity.
Which is catastrophic.
Utterly catastrophic. That causes peritonitis, which rapidly leads to severe sepsis and, historically, death.
So given that whole terrifying cascade, the surgical risk of just cutting the organ out was always viewed as significantly lower than the risk of waiting around.
Absolutely.
But recently, we've seen a massive shift. The medical community started using antibiotics as a safe, effective alternative to surgery for uncomplicated cases.
Right, which was a huge deal.
Yeah, it was. And to visualize this shift, think of the appendix like a small, dead-end pressure valve on a water pipe in your house. The old protocol was to immediately call an emergency plumber to rip the wall open, cut the blocked valve out, and seal the pipe. That's the surgery.
Nice analogy, yeah.
Then, the newer protocol became, hey, maybe we don't need to rip the drywall open. Let's just pour some industrial-strength chemical drain cleaner down the system to dissolve the blockage. And that represents the heavy dose of intravenous antibiotics.
Right, and that chemical approach, using broad-spectrum antibiotics, suppresses the inflammatory fire. It tackles the bacterial overgrowth without requiring the structural damage of a surgical incision, or the risks of general anesthesia, or the extended physical recovery of an actual operation.
But this new 2024 study by Erisho and colleagues out of Sahlgrenska University Hospital in Sweden asks a totally radical question. What if we just watch the pressure valve for a bit?
Just do nothing, essentially.
Yeah. What if the blockage is minor enough that the body's internal plumbing system will just clear it on its own? In other words, is jumping straight to the heavy-duty antibiotics actually overtreatment? Are we unnecessarily exposing patients to powerful drugs, disrupting their microbiomes, when their bodies could just handle it natively?
What's fascinating here is the methodology they use to actually answer that. Because you cannot safely take a random, unfiltered group of people with severe abdominal pain and just do nothing.
No, that would be clinical negligence.
Exactly. So this study required incredible precision. They utilized a block randomization designed to sort their patients into two groups, those who got antibiotics and those who got nothing but observation.
And block randomization is a crucial detail here for this deep dive. If you just flip a coin for every patient walking into the ER with appendicitis, heads you get drugs, tails we just watch you run the risk of statistical clumping, especially in a smaller study.
Right, you could get a very uneven distribution.
Yeah, you might accidentally end up with all the older diabetic patients in the observation group and all the young, healthy 20-somethings in the antibiotic group. That completely skews your data. So, block randomization forces the groups to be evenly balanced across critical variables. They created these blocks based on age, ensuring everyone was between 18 and 60, and crucially, based on their systemic inflammation markers.
And those inflammatory markers are the absolute linchpin of the entire study design. They didn't accept just anyone with appendicitis. They set very strict, very low biological thresholds for inclusion.
How low are we talking?
Specifically, a patient's white blood cell count, or WBC, had to be less than 13,000 per microliter. And furthermore, their C-reactive protein, or CRP, had to be less than 60 milligrams per liter.
Okay, let's break down what those numbers actually represent physically in the bloodstream. Because the normal white blood cell count generally hovers between, 4,000 and 11,000?
Roughly, yes.
So capping the eligibility at 13,000 means these patients definitely have an elevated count. Their neutrophils, the immune system's first responders, are marshaling for a fight. But it's a minor skirmish, not a massive, overwhelming systemic infection.
Right, they are sick, but they aren't crashing.
And CRP is a protein manufactured by the liver and pumped into the bloodstream in response to inflammation. A level of 60s is elevated, showing the body is reacting, but again, it's on the extreme mild end of the acute appendicitis spectrum.
Yeah, and they combine those very specific mild laboratory values with classic clinical characteristics. So the patients had to have localized pain in the lower right quadrant and radiographic imaging confirming an inflamed appendix.
Like a CT scan or an ultrasound.
Exactly. But they could have absolutely no signs of an active rupture, no abscess, and no severe complication like an appendicolith, which is a calcified stone that won't just dissolve on its own. By doing this, they isolated a very specific demographic. Adults with early, mild, completely uncomplicated acute appendicitis.
Okay, so they curate this highly specific group of patients with a mildly blocked pressure valve. Then they split them into two arms. The study group received what is rapidly becoming the newer standard of care, an early, aggressive antibiotic regimen. They were admitted to the hospital and immediately given intravenous piperacillin and tazobactam.
Which is a very potent combination. Piperacillin is a beta-lactam antibiotic that essentially punches holes in the bacterial cell wall. But gut bacteria are smart, right? Many of them produce an enzyme called beta-lactamase just to destroy the antibiotic.
So that's where the tazobactam comes in.
Right. Tazobactam is added because it acts as a chemical shield. It inhibits that bacterial enzyme so the piperacillin can actually do its job. After a few days in the hospital, these patients were then sent home on a course of oral ciprofloxacin and Flagyl for 8 to 10 days. So it's a very robust, broad-spectrum chemical attack alongside active observation in the hospital.
Meanwhile, the control group received classic active wait-and-see observation. 0 antibiotics, nothing but intravenous fluids and pain management.
Just letting the body do its thing.
Exactly. They were admitted, put in a hospital bed, and watched closely with serial abdominal exams and repeated blood tests to see if the disease would naturally regress on its own or if their condition would worsen.
And we really should emphasize the ethical safety net here. Nobody was just being abandoned to see if their appendix would burst.
Right, that's important.
In both groups, if there was no clinical improvement within 24 to 48 hours, or if their vital signs or pain scores worsened, the observation phase ended immediately, and surgical exploration, the appendectomy, was offered. The surgeons were actively managing the patients, making real-time clinical judgments.
So the showdown is set. Antibiotics plus waiting versus waiting completely barehanded. The primary outcome they were tracking was whether the patient ultimately needed an appendectomy during that initial hospital stay. Let's look at the data. The group that received the heavy-duty antibiotics had a 28% rate of ending up in the operating room.
Yeah.
So for 28% of them, the drugs failed to clear the blockage, or the patient didn't improve fast enough, and the surgeons took the appendix out. But the control group, the wait and see with no antibiotics group, they had a 53% rate of appendectomy.
Statistically, that difference is profound. The study generated a p-value of less than 0.004 for that primary outcome.
Let's contextualize that p-value for a second. In medical research, a p-value tells us the probability that the difference we are observing between the two groups is just a random fluke of the universe. Generally, the scientific community accepts a p-value of less than 0.05, meaning there's less than a 5% chance the results are a coincidence. That's statistically significant.
Right.
A p-value of 0.04 means there's only a 4 in 1,000 chance that this difference happened by accident. It firmly proves that giving antibiotics objectively, measurably prevented the need for surgery compared to just watching and waiting.
It clearly validates the pharmacological approach for preventing immediate surgery. However, the inverse of the control group's data point is equally, if not more, fascinating from a biological perspective.
Oh, absolutely. If 53% of the control group failed observation and needed surgery, that means 47% of people who walked into a hospital with radiologically confirmed painful acute appendicitis who received 0 antibiotics and 0 surgery, just naturally healed.
Which is incredible.
Nearly half of them. Their bodies cleared the blockage, the inflammation subsided, and the pressure valve unclogged itself. How does the human body actually pull that off without our help?
It speaks to the incredible resilience of the peritoneal immune system. So when the appendix becomes mildly inflamed, the body doesn't just sit idly by. We have this structure called the omentum.
Right, I've heard it called the abdominal policeman.
Exactly. It's a large apron of fatty tissue rich in immune cells that basically drapes over the intestines. It literally migrates toward the inflammation. It physically wraps around the inflamed appendix to wall it off from the rest of the abdomen. Concurrently, localized macrophages, which are like the garbage collectors of the immune system, begin engulfing the translocating bacteria, while the inflammatory fluid exudate slowly reabsorbs. If the internal pressure hasn't reached the point of total ischemic necrosis, that localized immune response can actually win the battle. It reduces the swelling and allows the appendix to drain naturally back into the cecum.
That is wild. We've spent a century thinking of the appendix as this helpless organ that immediately self-destructs the second it gets blocked. But half the time, the body's internal plumbing team can handle it if we just give them a minute.
Yeah, if the conditions are right.
But of course, avoiding surgery on a Tuesday is great, but appendicitis has a nasty habit of recurring. If your body fights it off today, but you end up back in the ER needing an appendectomy 3 months later, the initial conservative treatment wasn't really a long-term win.
Exactly. Avoiding the operating room initially is only half the clinical picture. The researchers needed to know the durability of this non-operative approach. So to track that, they utilized a robust statistical method known as a life table analysis, stretching their follow-up from day 5 all the way out to 1,200 days after the initial hospital visit.
A life table analysis is essentially a survival curve, right? Like, imagine you have 100 people running a multi-year marathon, and the event you're tracking is dropping out of the race to get your appendix removed.
Yes, that's a perfect analogy.
The life table analysis logs exactly at which day or month a patient's conservative treatment officially fails, and they cross over into needing surgery. It plots those failures over time, taking into account that some patients might move away or drop out of the study for other reasons.
That is an excellent way to visualize it. It accounts for time to event data. And over that 3-year marathon, the life table analysis showed a sustained, time-dependent advantage for the antibiotic group. The antibiotics consistently prevented surgical exploration at a superior rate.
Give us the numbers on that.
Over time, the success rate of avoiding surgery in the antibiotic group slowly dropped from 72% down to 50% as some patients experienced recurrences. But the control group's success rate dropped from 47% down to 37%. And this long-term difference was also statistically significant with a p-value of less than 0.03.
Okay, so the data unequivocally confirms that early aggressive antibiotics are statistically superior to traditional wait-and-see observation, both in the immediate hospital setting and over a 3-year timeline. The chemical drain cleaner works, but I have to push back here.
I know exactly where you're going with this.
Yeah, because while the statistics inside the trial are tight, the screening numbers for getting into the trial reveal a massive real-world catch.
You are targeting the primary methodological limitation of the study, and it is a crucial critique. Let's hear it.
The researchers screened 1,019 patients who came through the emergency department with suspected appendicitis. Out of those 1,000-plus people, only 12.4% were actually eligible to even participate in the study based on those strict criteria we broke down earlier. They ended up with a final participant pool of just 126 people, 69 in the antibiotic group and 57 in the control. If nearly 90% of the people walking through the doors with appendicitis are disqualified because their white blood cell count is 14,000 instead of 13,000, or their CRP is 75 instead of 60, doesn't that severely restrict the utility of these findings? Is this actually a new protocol or just a very rare exception?
The generalizability of these findings is absolutely constrained by that 12.4% eligibility rate. This data does not support a blanket recommendation to stop operating on appendicitis. If a patient arrives with a white count of 18,000 and a CRP of 150, this study provides zero evidence for managing them conservatively.
This is not meant for them.
Right. Furthermore, the small final sample size of 126 patients severely limits the statistical power to detect rarer but severe complications.
Which brings up what the study completely failed to measure, the secondary outcomes. They tracked the primary binary outcome beautifully. Did the patient need surgery, yes or no? But they didn't rigorously measure the collateral damage of the treatment.
That's a great point.
Because piperacillin, tazobactam, and ciprofloxacin are not benign Flintstones vitamins. They absolutely obliterate your gut microbiome. They carry real risks of severe gastrointestinal issues, allergic reactions, and most dangerously, opportunistic infections like Clostridioides difficile or C. diff. If a patient successfully avoids an appendectomy but ends up hospitalized 3 weeks later with severe life-threatening C. diff colitis from the antibiotics, the overall risk-benefit calculus flips entirely.
And we also have to consider the surgical complexity for the patients who ultimately failed the conservative arm. If you are in the observation group, your inflammation progresses, and 48 hours later you need the surgery anyway, did that waiting period allow the appendix to become more friable, more inflamed, and adherent to the surrounding tissues?
Yeah. Does waiting make the surgery worse?
Exactly. Did a delay turn what would have been a straightforward 30-minute laparoscopic procedure on day 1 into a complicated 2-hour open surgery requiring a larger incision and a longer recovery on day 3? The study does not provide granular data on the operative difficulty or the complication rates for the crossover patients.
So the Swedish study proves our bodies sometimes fix themselves in ways the surgical playbook doesn't expect. It proves we can assist that spontaneous regression safely with antibiotics, but only for a highly curated, mildly inflamed demographic. But that same unpredictable biology can also betray us when we do need the medical playbook to work.
Which is a perfect segue.
Yeah, that brings us to the other side of this duality. We are leaving the surgical suite and moving into the intensive care unit to look at a hidden, silent threat: blood clots.
This is a vital progression in our discussion, because while an inflamed appendix is highly symptomatic, vocal, and localized, the threat we are analyzing now is systemic, largely asymptomatic, and can be instantaneously catastrophic. We are examining venous thromboembolism, or VTE.
Let's set the stage with our second source. This is the 2023 Poggiawa study published in the Journal of the American College of Surgeons. They focus exclusively on emergency general surgery patients, or EGS patients. And the statistics they present to frame this issue are genuinely terrifying.
They really are.
Anyone undergoing a major surgical procedure is at an elevated risk for developing a VTE, which usually starts as a deep vein thrombosis, a clot in the deep veins of the leg. And that clot can break loose, travel up through the heart, and wedge into the lungs as a deadly pulmonary embolism. But for patients undergoing emergent surgery, an unplanned crisis where you are rushed to the OR, that risk of a blood clot is effectively doubled.
And to understand why that risk doubles, we have to look at the pathophysiology of trauma and emergency. In 1856, a physician named Rudolf Virchow described 3 broad categories of factors that contribute to thrombosis, which we now call Virchow's triad.
Endothelial injury, venous stasis, and hypercoagulability,
Yeah.
right?
Exactly, and an emergency surgery patient perfectly embodies all 3. First, there is physical tissue damage from the acute disease or the surgical incisions themselves, causing endothelial injury. Second, the patient is sedated and immobilized in a hospital bed, meaning the calf muscles aren't pumping blood back to the heart, leading to severe venous stasis where blood pools in the extremities.
And the third factor, hypercoagulability, is basically the body's survival mechanism gone wrong. When you are in an emergency state, say a perforated bowel or a severe traumatic injury, your body is in a state of profound physiological shock. It assumes you are bleeding, so it aggressively activates the coagulation cascade. Your blood literally thickens to plug potential leaks. Add all 3 of those factors up and you have a biological environment practically begging a blood clot to form.
Exactly. To combat this perfect storm, the standard hospital playbook mandates VTE prophylaxis. The cornerstone of this defense is chemical blood thinners, most commonly a medication called enoxaparin.
All right, enoxaparin. It's a low molecular weight heparin, or LMWH. It is the absolute workhorse of surgical floors worldwide. Historically, when dosed correctly, this chemical prophylaxis can mitigate the risk of a blood clot by anywhere from 50 to 70%. But here's where it gets really interesting.
The blind spot.
Yes. The current protocol has a massive, largely unquestioned blind spot. When an EGS patient arrives on the floor, the standard protocol dictates prescribing a uniform standard dose of enoxaparin to almost everyone. It's pre-populated in the electronic medical record. Unless the patient is morbidly obese or has pre-existing documented chronic kidney failure, they get the exact same amount of drug.
The underlying assumption of that standardized protocol is that a standard dose of the medication will yield a standard, predictable prophylactic effect in the bloodstream.
Right, but think about it like this. It's like issuing the exact same standard-sized umbrella to everyone who walks outside, regardless of the weather. That standard umbrella works perfectly fine if you're a stable, healthy outpatient caught in a light drizzle. But emergency surgery patients aren't in a drizzle. Their internal biology is a raging hurricane. Their metabolisms are hyperaccelerated, their vascular permeability is fluctuating, and their fluid levels are shifting massively. We just hand them the standard umbrella, assume it's keeping them dry, and we almost never actually check to see if they're getting soaking wet.
Checking to see if they're getting wet is precisely what the researchers at this single institution set out to do in 2023. They recognize that the chaotic physiology of an EGS patient is fundamentally different from a stable elective surgery patient, and they hypothesized that the standard dosing protocol was failing. But to prove it, they needed biochemical verification.
Because you obviously can't just walk into a patient's room and ask, hey, on a scale of 1 to 10, how thin does your blood feel today?
Exactly, that doesn't work.
You need a specific laboratory test. And that brings us to the concept of anti-factors monitoring, or efficacy.
To understand what this test measures, we need to briefly map the coagulation cascade. Your blood doesn't just spontaneously turn into a solid jelly. It clots through a highly complex sequential chain reaction of different proteins in the blood, which we call coagulation factors.
Yeah, the whole cascade.
Yeah, there is an intrinsic pathway activated by internal trauma and an extrinsic pathway activated by external tissue damage. Both of those pathways converge at a crucial intersection point. Factor zagus, that's the Roman numeral 10, and the letter A.
So factor A is essentially the main engine of the blood clot. It takes the precursor prothrombin, converts it into active thrombin, which then turns fibrinogen into the sticky fibrin mesh that physically forms the clot. If factor A is the engine, the blood thinner enoxaparin is basically throwing sugar into the gas tank.
That is a highly accurate functional description. Enoxaparin works by binding to another protein in your blood called antithrombin III. When it binds, it causes a conformational shape change that exponentially accelerates antithrombin's ability to hunt down and neutralize factors A. Now, here's a clinical challenge. We cannot easily draw blood and measure the actual physical mass of the enoxaparin molecules floating around. The half-life is too tricky, and the molecules vary in size.
But you can measure how effectively the drug is doing its job. You can measure how much of the factors A engine is successfully being shut down. That is what an anti-factors A test is. It's a functional assay. You are measuring the inhibiting effect of the drug, not the mere presence of the drug itself.
Precisely. And in surgical critical care literature, there is a rigorously established target therapeutic range for this specific prophylactic drug. To ensure a patient has sufficient chemical protection from forming blood clots without crossing over into the danger of spontaneous bleeding, their anti-factor Za level needs to sit neatly between zero point 0.3 and zero point 0.5 international units per milliliter. If their blood tests in that range, the umbrella is open and they are protected.
Okay, so the researchers constructed a 6-month prospective cohort study to actually measure this in their EGS population. Let's look at the parameters because they designed this very carefully to test the standard protocol specifically. They enrolled 81 adult emergency general surgery patients, but they explicitly excluded any patients who had chronic kidney disease, acute kidney injury, active bleeding hemorrhages, or who were pregnant.
And that exclusion is critical.
Right, they excluded them because all of those conditions fundamentally alter how blood thinners are metabolized or cleared. They wanted a perfectly clean look at the standard protocol on patients with seemingly normal organ function.
And they adhered strictly to the hospital's standard weight-based dosing algorithm. If an enrolled patient had a body mass index, or BMI, of less than 40, they received the standard 40 milligrams of enoxaparin as a subcutaneous injection once a day. If their BMI was over 40, classifying them as morbidly obese, they received an adjusted standard of 40 milligrams twice a day.
Then they deployed the anti-factor Ziga blood test to see if it was working. And the timing of this blood draw is everything. They drew the blood precisely 3 to 6 hours after the patient received their third dose of the medication. Why the third dose, and why that specific 3 to 6 hour window?
Pharmacokinetics dictate the timing. You must wait for the third dose because that is roughly when enoxaparin achieves a steady state in the human body.
Steady state meaning?
When you give the first dose, the body processes it and clears some of it before the next dose arrives. It takes a few continuous cycles for the drug's accumulation and the body's elimination to balance out into a consistent baseline level. And you test specifically 3 to 6 hours after the injection because that time frame represents the peak concentration of the drug in the bloodstream.
So you're checking it at its strongest.
Exactly. You are trying to measure the umbrella at its absolute widest, most protective point. If the drug isn't hitting the protective threshold at its absolute peak, it certainly isn't protecting them 18 hours later when the drug is wearing off.
So the setup is flawless. They have 81 patients, they filtered out the biological outliers, they are administering the standard protocol dose, and they are testing the blood at the exact, perfect pharmacokinetic moment to witness maximum protection. The target, again, is a score between 0.3 and 0.5. The results of this test are genuinely staggering.
The findings indicate a systemic failure of the protocol. Out of the 81 monitored patients, 75% were placed on the standard 40 milligram daily dose. When the researchers analyzed the peak blood draws, a massive 87.7% of the patients had an initial anti-factor Za measurement that fell below the 0.3 protective threshold.
87.7%. That is nearly 9 out of every 10 patients failing to achieve protection.
And we must emphasize the severity of the failure. These patients weren't just missing the 0.3 mark by a fraction of a point. The mean measurement across that failing group was an abysmal 0.16 IUML. They were essentially operating at half the required protective capacity at the drug's absolute peak.
So what does this all mean in a hospital setting? If you translate those biochemical numbers into the reality of a surgical ward, it means nearly 9 out of 10 emergency surgery. Patients in this study were lying in their beds, physically immobilized, pumped full of inflammatory markers, and completely unprotected by their standard dose of blood thinners.
It's deeply concerning.
The surgeon ordered the drug, the pharmacy dispensed it, the nurse injected it, everyone checked the completion box on the electronic chart. But biologically, the umbrella was closed. It's a terrifying illusion of safety.
It is the definition of treating the chart rather than treating the patient. And the clinical data actually grows more alarming when we examine the subset of patients who remained hospitalized long enough to have their regimens actively adjusted by the research team.
Right, because the researchers didn't just log the failure and walk away. For the 27% of patients who were still admitted after that first low test, the clinical team actively intervened. They saw the low scores and bumped up the doses.
Which is what you'd expect them to do?
Yeah. The majority of these underprotected patients were increased to 30 milligrams or 40 milligrams twice a day. They literally doubled the frequency of the medication. They administered 3 more doses to reach a new steady state, and they ran the anti-factor Za test again. Tell me what happened when they doubled the dose.
Even after aggressively increasing the drug exposure, An astonishing 82% of those retested patients still remained below the zero point 0.3 target range.
That is just, wow.
Let me reiterate that for clarity. Even when the standard dose was doubled, 8 out of 10 emergency surgery patients still did not exhibit enough factor XIA inhibition to hit the minimum biochemical threshold for clot protection.
If we connect this to the bigger picture, how is that physiologically possible? We've already ruled out chronic kidney failure in the study design. Where is the drug going? Are their bodies just chewing it up and spitting it out?
That is exactly what is happening, and it brings us back to your hurricane analogy. The standard 40 milligram dosing of enoxaparin was originally developed, calibrated, and validated on relatively stable, non-emergent patients. But emergency general surgery patients are experiencing profound physiological chaos. We discussed the hypercoagulability earlier, meaning the drug has more work to do just to break even. But more importantly, we have to look at the kidneys. Enoxaparin is primarily cleared from the body via renal excretion. In a healthy resting adult, the kidneys filter blood at a steady, predictable rate.
But in an emergency trauma response, the heart is pumping frantically. You have a massive increase in cardiac output.
Exactly. That hyperdynamic circulation pushes a much higher volume of blood through the kidney's filtration system, the glomerulus. Furthermore, these patients are often aggressively resuscitated with liters of intravenous saline in the ER to stabilize their blood pressure.
Which waters everything down.
Yes, this fluid loading literally dilutes the concentration of the drug in the plasma. This combination of increased cardiac output and fluid resuscitation leads to a phenomenon known as augmented renal clearance, or ARC. The kidneys are hyperfiltering. They are flushing the enoxaparin out of the system at a radically accelerated pace.
So the nurse injects the drug into the tissue, it absorbs into the bloodstream, but the revved-up emergency physiology acts like a supercharged filtration pump. It just burns through the medication and dumps it into the urine in a fraction of the normal time.
Precisely. They are metabolizing and excreting the prophylaxis so rapidly that a standard dose, or even a doubled dose, is completely overwhelmed. The fundamental conclusion of this paper is that standard population-based LMWH dosing provides drastically inadequate VTE prophylaxis for the emergency surgical population because their real-time renal clearance rates are heavily augmented.
Now, I want to pivot to a fascinating clinical pearl from the data, because looking at those dismal failure rates, you would logically assume these patients were suffering catastrophic blood clots left and right. But thankfully, remarkably, the study notes that 0 patients actually suffered a symptomatic VTE during this 6-month study period.
Not a single one.
Not a single massive pulmonary embolism or severe deep vein thrombosis was recorded. Interestingly, the study does note 2 patients had upper GI bleeding events. And ironically, both of those bleeds occurred in patients who were in the low antifactor XIA group, meaning they weren't even biochemically overthinned when they started bleeding.
The 0% symptomatic VTE rate is certainly a relief for those specific patients, but from an evidence-based perspective, this is where we must apply a rigorous methodological critique. We cannot allow the absence of a catastrophic clinical event in a small cohort to negate the glaring biochemical failure the study uncovered.
Let's aggressively break down those limitations, because 81 patients is a very small pool to draw major protocol-changing conclusions from, right?
It is a significant limitation. The researchers transparently noted that 12,220 patients were evaluated by the Emergency General Surgery Service during those 6 months. Only 81 ended up enrolled, receiving the standard dose and staying long enough to be tested. That creates a massive potential for selection bias.
Because they had to stay in the hospital for a while.
Right. Think about the logistical requirement to remain in the hospital long enough to receive 3 daily doses of enoxaparin. That automatically filters out all the patients who had a quick minor procedure, like a simple laparoscopic gallbladder removal, and went home on post-op day 1 or 2. The study design inherently skews the sample toward the most critically ill patients who required extended hospitalizations.
Which might perfectly explain why their metabolisms were so chaotic and their kidneys were hyperfiltering the drug in the first place. It was a self-selecting group of the sickest, most inflamed patients on the ward.
Exactly. We also have to critique the heterogeneity of the sample. The researchers did not separate the operatively managed patients from the non-operatively managed ones in their final analysis.
Oh, really?
Yeah, out of the 81 patients, 17 were non-operative, meaning they were admitted with an acute emergency, like severe pancreatitis or a bowel obstruction, but managed medically without actually going under the knife. The inflammatory and coagulation risk profiles for a patient with a massive surgical incision are different from a patient managed medically. Blurring them together in a small sample muddies the exact risk profile we are trying to analyze.
And going back to the fact that nobody had a symptomatic blood clot, the key operative word there is symptomatic.
Yes, this is perhaps the most critical limitation regarding the outcome data. The study protocol did not mandate routine screening for VTEs prior to discharge.
So they weren't looking for them.
They did not perform routine duplex ultrasounds on everyone's legs just to check. They only investigated for clots if the patient started explicitly showing symptoms like severe asymmetrical leg swelling or sudden shortness of breath indicating a pulmonary embolism. We know definitively from decades of vascular research that a massive percentage of deep vein thromboses are entirely asymptomatic.
They just sit there.
They form and sit quietly in the deep veins of the calf without causing immediate pain or swelling. So, given the biochemical proof that 87% of these patients lacked chemical protection, it is highly likely that asymptomatic microclots were actively forming in this population and were simply missed because nobody looked for them.
So the lack of a smoking gun doesn't mean the gun wasn't fired. It just means the bullet didn't hit anything vital before the patient walked out the hospital doors.
Correct. The biochemical reality of the vulnerability remains absolute. The prophylactic barrier we assumed was there simply was not.
Okay, let's pull all of this complex physiology and data together. We've gone incredibly deep into two very different corners of emergency medicine today. On one side, we looked at the appendicitis study out of Sweden. We learned that blindly following the century-old surgical playbook and operating on every mildly inflamed appendix might be significant overtreatment.
Right.
We learned that for a very specific, carefully selected subset of patients, relying on the body's natural immune response and targeted antibiotics is statistically proven to be a superior, less invasive approach.
And on the other side of the duality, analyzing the enoxaparin pharmacokinetics in emergency surgical patients, we learned the exact opposite lesson about a standard playbook. We learned that blindly prescribing a standard one-size-fits-all blood thinner dose is resulting in severe, widespread, and hidden undertreatment. We learned that active, individualized biochemical monitoring, checking those anti-factor Zeta levels, is desperately needed in the critical care setting because our population-based assumptions are failing the individual patient nearly 90% of the time.
What unites these two deep dives is a singular, powerful theme. We're witnessing the death of the one-size-fits-all medical protocol. The era of just blindly following an algorithm, whether it's an automatic trip to the OR or an automatic dose of a drug without continuously verifying its impact on the specific human being in the bed, is coming to an end.
I completely agree. Medicine, particularly critical care, is undergoing a fundamental paradigm shift. We are moving away from treating the static disease protocol and moving toward treating the individual patient's real-time biology. Whether it is meticulously tracking the exact white blood cell count to decide against surgery or actively measuring the exact factor Z inhibition to triple a failing drug dose, the future of medicine is active, continuous verification.
Why should this matter to you? Why should you care about the nuances of block randomization, or the mechanics of augmented renal clearance, or the exact therapeutic ranges of anti-factor ZAL levels? Because if you or someone you love ever ends up in an emergency surgical ward, you don't just want the generic standard playbook.
Yeah, familiar.
You want clinicians who understand the chaos of your specific biology. You want a medical team that doesn't just check the boxes on a chart, but actively verifies that the treatments are actually working for you right in that critical moment.
You want precision medicine driven by real-time data, not just presumption based on old habits.
Exactly. We started today talking about the comfort of the standard playbook. The idea that if a pressure valve is blocked, we automatically cut it out. Or if it's raining, we automatically hand out standard umbrellas, assuming they'll keep everyone dry. But as we've seen, sometimes the plumbing can fix itself with a little chemical help and a watchful eye. And sometimes you're standing in a biological hurricane where a standard umbrella is completely terrifyingly useless.
It forces a necessary reevaluation of every intervention we consider routine.
Which leads me to a final thought for you to ponder. If a heavily researched, universally prescribed standard dose of a life-saving blood thinner is secretly leaving nearly 90% of emergency patients totally unprotected, what other standardized medical treatments are we taking for granted right now? Where else in our healthcare system are we completely flying blind, confidently checking the box, but never actually stopping to verify if the medicine is doing its job? Think about that next time you hear the word standard procedure. Thank you for taking this deep dive with us today. We'll see you next time.